Dr. Badruddin will be in shortly. While I'm speaking, if anything kind of perks your interest and you're curious to know more about it, that's why he's going to come in. What Dr. Badruddin wanted me to do was I had gone with Jen Bianc, the stroke coordinator, and a couple other nurses to this conference put on by the American Heart Association back in February. And what he wanted from us nurses was to bring material back to present that would help improve the program. And I was talking with Jen this morning, and I said, really, a lot of what I'm presenting is so basic, but it's simple little basic things that over time we get wrong. And my intention really is to present this material as an opportunity for all of us to feel more comfortable learning and reaching out regarding learning opportunities. I won't go too far into it, but we know how tough it's been the last couple of years. It's getting even tougher, so that puts more stress on us as nurses sometimes, and it can affect us. So the more we know, the better we are at our jobs, and I think truly that helps us kind of at the end of the day feel good about what we're doing. Okay, off my soapbox. So what's on the agenda? We're going to look at the NIH stroke scale, like knowledge, skills. Also looking at an interesting study, does obtaining that certification assure that you're competent or even confident to actually do an NIH correctly? A couple things brought up at the conference as far as NIH goes that nurses nationwide tend to get wrong. These two kind of go together, the gaze and visual disorders, and then neglect extinction disorders. Neglect extinction disorders get missed completely. Also, motor weakness versus ataxia, how to interpret that and score that. That was one of the first things I talked to a lot of nurses when I got back, because I was like, I think I've been doing this wrong a lot, and I was hearing a lot of feedback. I asked a couple doctors, they said, yes, I see a lot of motor weakness being, marked as ataxia, but we'll go into that more. Also, I'm going to talk a little bit about stroke nursing navigator position. It's something that's being implemented more in comprehensive stroke programs. And then I'm just going to bring up something, Dr. Badruddin was on the floor yesterday, and it's kind of an upcoming chance to increase your skills and knowledge. You see the little celebration guy. I think it's a pretty cool thing coming up later in the fall. We'll get to that. So, NIH scale, severity, measurement, why, who, when to use it. This is going to include that neglect, weakness versus ataxia, and the certification, whether or not it makes us competent and confident. The severity of the measurement, why, who, and when we use it. It's an assessment tool used by accredited individuals to measure the severity of strokes. Some language in an effort to reduce errors. It was designed actually to be objective. And understanding the value of the number that you attribute to someone's NIH can help in communicating to the family, to the interdisciplinary teams, kind of what state this person is in. And I want you to remember what I just said, because at one point, I'm going to completely go the other direction. And this is a problem with the NIH. For the most part, it is very reliable, but there is one thing that it's pretty unreliable about when it comes to scoring and giving you an indication, just hearing the score, how severe this is. So highest reliability seen in trained nurses, actually higher than neurologists. And I was hoping Dr. Badruddin was here so I could kind of giggle, but he's not here right now. But supposedly us trained nurses are the most reliable. Items we're less reliable on: dysarthria, ataxia, facial droop, and extinction. I'm not going to go too much into facial droop, but I recall even one time being on a stroke code in the ED and the stroke nurse debating with the ED doctor about a facial droop. And this is just an example. And finally, the ED doctor said, "Show us your driver's license." Sure enough, that was just her face. So we won't go too much into that, but facial droop sometimes is something that's hard to assess. Severity of the score, we all kind of know this. I think we've seen this picture before: minor stroke, moderate, up to severe. What I wanted to point out here, though, is when the NIH is more reliable, if someone's under a 4, they can be 75% independent 1 year post-stroke. What this is important for is allowing families to understand outcomes. Stroke is so unique compared to other debilitating and even life-terminating conditions, whether it's heart or kidney disease, even like diagnoses of cancer that take years. Stroke hits you and you're disabled, sometimes severely disabled. Your life has changed forever, and it's a lot to take in immediately. So understanding these scores, and if it's greater than a 15, this is going to be associated with longer term dependence. Also, for us as practitioners, we see that early improvement correlates with better outcome. Early deterioration increases length of stay and worse outcomes, which I think we all kind of say, yeah, we've seen that firsthand. Why we do it, this is kind of obvious. I was hoping a little bit more newer nurses were here. Assessment of initial severity of the stroke, identifications of changes. We know that somebody starts changing in the room. I remember being a new nurse, I just wanted to call 555, but you can do an NIH, you can bring it out pretty quick and actually see if, it warrants calling up a neurologist. Do we need to do some type of intervention like new imaging? It, as I said, estimates the complications that a patient will have, even moving into rehab, and we'll go more in depth into that coming up. The length of stay they're going to have, the future care destinations, all this, again, we'll go more in depth into. I mentioned that it helps inform families better what to expect. I mean, a lot of times we really can't tell them exactly what's going to happen, but we can kind of give them a general idea based on what we're seeing severity-wise just by doing an NIH and how they've been progressing. And it's also used as a rating system for the quality of the hospital in the end. And we'll go more into that too with like nursing navigators and how that's kind of helps improve the quality of the hospital and the rating. Why we do it, allows for localization of stroke symptoms. You can work backwards, figure out which blood vessels are involved based on what symptoms you're seeing. Yes, we have imaging, but if we send somebody to imaging with these type of stroke-like symptoms that were assessed properly, then it allows the one interpreting to localize a stroke based on symptoms. If it appears to be a greater area, what's something maybe we're looking at if there's stroke-based symptoms and we can't localize it? What mimics strokes? Epilepsy and migraines can mimic stroke-like symptoms when we're doing NIHs. Stroke and clinical trials. This is obvious: suspected ischemic versus hemorrhagic strokes. It was far more useful than using the Glasgow Coma score. An example of that is just looking at the unilateral versus a bilateral weakness. There's no guideline actually for when and how often you should do an NIH. Hospitals have their own length for how long they do it, but there is no standard based on the NIH for how long you should do it. Any pre-hospital is pretty much unreliable just because they tend to be unaccredited users. There are trimmed down versions used by EMS. There's one called Hunter 8, Race, Act Fast. Some questions were raised at the conference about, hey, do we have any type of versions of a slimmed down version of the NIH we can teach. And they basically said, you know, that's garbage because it's really not that hard to pop one out real quick if you're familiar with how to do it. It also, those other ones tend to be unreliable. They miss things, they have erroneous findings. Another reason we do it, you know, we want to see if it's resolving prior to any thrombolysis, any obvious changes in condition. And you know, we always do this anytime we transfer from units or shift change. So NIH is only as good as you use it with your fellow employees. That increases its supposed objectivity when you compare it with another nurse. That's why we do those during handoffs.
Okay, so I have to say this. There is a guideline from Joint Commission regarding NIH.
Okay.
And it's 3 times it's mandatory. Upon admission, 24 hours post-admission, and upon discharge.
Okay.
Those 3 times you should do it. The 4th exception to that is when somebody has a material clinical change. There's a significant clinical change during their stay, then you may repeat it. You know, so I have been having discussion with Jen Bianco over the last 2.5 years or so regarding this every shift, every day. That's just way too much burden on nursing staff. So we don't need to be doing NIH stroke scale every so often. However, what people don't understand, and I want the group to understand and, you know, sort of put this message forward, there's a difference between an NIH stroke scale and neuro exam.
Yes.
A neuro exam is not an NIH stroke scale, and NIH stroke scale is not a neuro exam. A neuro exam is a neuro exam. So you should do a neuro exam every 4 hours or every shift or whenever, however often it's ordered, but that is different than an NIH stroke scale. Does that make sense? So it is very critical to understand the difference between the two and to know when to do which. You know, with NIH stroke scale it's pretty simple. Upon admission, 24 hours post-admission, and on the day of discharge. You want to know how sick they came in. You want to know if your intervention in the next 24 hours made any difference to them, and during the hospital stay, what is their net change? So you do it on the day of discharge. That's it. You don't need to do it more often than that. So when I last talked to Jen, she told me that change is coming pretty soon, where that will be part of the order set and that will go out in nursing education, that NIH is only supposed to be done on these 3 occasions, not more, not less.
Okay. And yes, the next slide, actually, they had suggested that after past 72 hours, that it was patient-specific. Severe strokes would prompt the possibility of needing early intervention, so you would be continuing to do them, while mild ones, it wasn't as necessary. And like you said, that's where you're doing more of your general neuro assessments, your Glasgow-Coma scale, and your general observation assessments. As brought up in the introduction, does obtaining an NIH certification assure nurse competence and confidence? So people shake their heads no initially. And it was pretty interesting because as a certified or comprehensive stroke center, documentation is needed within the first 12 hours of admission. This particular hospital during rounds started asking, they were noticing that their staff was a little iffy on whether or not they were confident, and also they were doing it incorrectly. It was brought up how that video that we see, it has not been updated since they originally did that first study. It's been over 30 years. It's quite terrible. There's the one with the ER and the guy, and you can barely hear him. That's something I remember talking with Jen and Bianca about, if doing like an in-house video where it was first person and you're directly seeing the assessment done would help newer nurses or even seasoned nurses maybe brush up from time to time. This could also be done with spinals too, because I know every once in a while we don't do those that often. Anyways, back to the study. During this 3-month period, they randomly selected nurses on both shifts. The nurses, it was on a scale of 1 to 5, not confident, somewhat confident, neutral, confident, very confident. The NIH was evaluated using two criteria: whether or not they were competent, 1 point for doing it correctly, 1 point for not doing it correctly, with the goal of being 100%. The results were spot checks greatly increased the nurse's confidence and brought attention to areas of improvement. The average baseline score for confidence was a 3.8. Of those nurses, 64 increased their confidence by 1 point, and 9% increased their confidence more than 1 point. Ultimately, 100% of the nurses achieved competency on these spot checks. So it's just something to think about. I know it's kind of maybe unnerving to think about somebody kind of grabbing you during your shift and saying, hey, I want to spot check you and see if you do this correctly, but I thought it was an interesting little study that this hospital chose to do as a CSC. Now we're going to kind of move on to understanding gaze and visual field disorders, which will also lead into nystagmus. Again, it was gaze and visual field disorders, nystagmus, neglect order disorders, and ataxia that were marked down as some of the most commonly mistakes made by nurses with the NIH. So we'll look at it kind of as anterior versus posterior circulation. We know these disorders are nystagmus, field cut, gaze preference, homogeneous hemianopia, diplopia, and the last one is fairly rare, but I put it on there anyways, intranuclear ophthalmoplegia. It's easiest to understand these categories too when we look at them by their territory of where these strokes are happening. We'll look at these 3 categories here. So we might be familiar with this visual. I believe this is part of our education too. It's a really good graphic, and we're going to look at it again here. But if you follow that yellow line, you kind of see that area where the optic chiasm is, and that's where you're going to really be dealing with whether or not it's binocular or monocular vision issue. All of us are probably pretty familiar with the actual scoring of the cranial nerve or cranial 2 visual fields. It's done improperly often depending on the patient's position. Of course, we know we were taught originally, mirror one another, test yourself, but I see a lot of people, and I was taught this way too, asking people to count fingers in quadrants. Do you guys do that? Okay, and that can cause problems because it has nothing to do with counting. All it has to do is whether or not the person can see it. And I believe the first person I ever saw doing it was Dan Latier, and he just wiggled his fingers in the quadrant. That's all we want to see, that they're seeing that movement. Otherwise, you can run into areas where your hand's turned, they have glasses on, the rooms, how they're set up. Always remember to have that one eye covered. I myself sometimes forget. And again, here's that rules of visual field localization. So for patients who have cognitive limitations or altered consciousness and poor attention, I'll see this a lot on NIHs. People will just say, oh, they're not, their altered mental status, I can't test them, but you can use confrontation. Anyone familiar with what that is? So going from the quadrants, and you just kind of take your finger and come in at their eye. Sounds a little mean, but you're just looking for them to flinch so they see them coming in. And again, we know the difference between binocular and monocular. MCAIs, best gaze, it's your cranial nerve 2, 6. Fairly familiar with the scoring, I'm sure. One tip that was brought up, because a lot of people do this too, we'll use Amanda as an example, you know, you say, look at my nose here, follow my finger. They said go all the way as far as you can. You really want to see, you know, you want to push that sclera. Not going all the way, you might actually miss nystagmus. Right way versus wrong way eyes. Right way we know, typically MCA territory, stroke, that's our forced gaze towards the side of the lesion, or wrong way is that forced gaze away from the lesion. Could be seizure, maybe non-convulsive, but wrong way eyes may not always be a seizure, but can be helpful in determining in other situations, and maybe Dr. Badruddin can speak to that.
Sure. No, we can talk to you about it after you're done.
Okay.
I'll let you finish.
Brainstem eyes. We're looking at the cranial nerve and placement. Since we're talking about eyes, we're going to look mainly at 3, 4, and 6, the midbrain and the pons. And I recognize this. This was actually used at the conference, but I recognize this even from our education here. And it's a little overwhelming when you see that picture, but it's not like we have to memorize all those ways that those eyes look. And as far as they spoke, cranial nerve palsy 4 and 6 is not very common in stroke. So we're going to mostly focus on 3. So with 3, we're looking more at the eyes deviating laterally and down. Also, we might notice pupils not being reactive, and that might be more likely related to space-occupying lesions. We'll see accommodation loss. This is kind of 2 where you can ask them to look at their nose, and if they look at their nose and they don't get that accommodation, it could be showing a sign of it. Another sign could be ptosis. These are localized mainly to like the posterior communicating, also the basal artery thrombus and subarachnoid hemorrhage etiology. Diplopia we won't talk much about, but most always caused by lesions that affect that ocular movement system in the brain stem, so our 2 or 4 and our 6, not the occipital lobe. This is usually involving ocular motor nerves or extraocular muscles. Moving on to extinction disorders, and this seemed to be one of the biggest ones too that gets missed by nurses. You know, we talked about how these scores can be done incorrectly. This video is over 30 years old. So some key points we'll be looking at is a review on neglect, the anatomy and physiology of neglect, and assessing neglect via the structure of the NIH. Because really, as Dr. Badruddin was even saying, this needs to be approached methodically. It's not the end-all be-all, the NIH. It's a communication tool for us. We need to include our other clinical skills, assessment skills, when we're looking at our patients. So, you know, neglect review. Key point to make is neglect is a phenomenon. That's a phenomena. It's an umbrella term for an inattention to space. So we might be talking about inattention, extinction, hemispatial neglect. The attention results in that ability to orient, report, respond to any stimuli contralateral to what side that injury is on the brain. One method we test is for extinction. Also seen in other brain injuries, abnormalities, most common is in hemispheric strokes, particularly right MCA strokes. And after 6 months, can still be seen 50% of the time in right MCA strokes. Probably can look at this fairly briefly, visual extinction versus sensory. Remember, this is about competing, and like I said, visual, we're gonna use that finger wiggle instead of actually asking people to count. Sensory is more double simultation. You might touch them on each side individually, and I've seen people do that, and they think, while they're not neglecting either side, they responded appropriately. You need to touch them at the same time. Another thing that is important to point out, it's on a gradient. So we understand what a gradient is. It's not like hemianopia, it's not this straight line. This makes it more difficult to assess. You might not see it on the first assessment. You might have to do a longer assessment on this patient, or you might see it once, might come back and it's gone. It can be very tricky to do. This is also where it's helpful to ask another RN just to get their perspective on it. There's controversy around kind of the anatomical structures that cause neglect. It may not be related to one area. It might be a network of areas, especially connective areas, damaged areas involving white matter tracts, corticals, and subcortical regions. And maybe Dr. Badruddin can go. I was kind of curious about the subcortical regions. Also how white matter tracts having this dysfunction relate to manifesting neglect. Interhemispheric dysfunctions cause, we know, that that overactivity on one side of the brain, which leads to that presentation clinically of the patient exacerbating neglect to one side. We can see this in functional MRIs, especially the right MCA, where the left side of the brain just takes over. That's what we know, that clock drawing, where they only draw half the clock, or we come in and only half their tray is eaten. Dan and Van, which I know we're all familiar with, the dorsal attention network and the ventral attention network. Dan is simply spatial. Where am I at in space? This is more our white matter tract disruption of connectivity, whereas Van is more ischemic and hemorrhagic damage to brain tissue. Van is imperative to arousal, that sustained attention, and also reorienting a person to attention. Hemianopia and neglect, this is the thing, it can occur simultaneously in the clinical setting. It can make it really difficult. It's up to the nurse, the bedside individual, doing this assessment to figure out whether one or both are occurring. For example, if a patient has hemianopia, focus on that double simulation for sensation to assess for that neglect. Conversely, we would focus, if a patient had dense sensory loss, you would want to work with their visual fields to assess for that neglect. So we kind of already went over this in the clinical setting. I brought it up, the double simulation test first. Had them close their eyes, you touch the left, the right, and both. And they suggested too, just go ahead and have the person raise their hand to either side you're touching. It gets rid of the your left or my left situations with dense sensory loss. We can use visualize, the visual testing. That's the whose hand is this? Show them their hand. Do they recognize their own hand? An interesting question here, is neglect ever untestable? And that example would be patient scores a 3 on 1A for level of consciousness. In that instance, neglect is automatically scored a 2. Kind of mentioned this before too, also visual neglect. You can have the patient look at their nose, do the wiggle finger test, left, right, both. Best to have patient point to what side. Be mindful of any quadrant deficits, again, that they potentially might have, because that can cause issues with testing for neglect. This is where that visual field issues, if they're having, can cause problems. If they do have those deficits, go to the double simulation exam where you're actually touching. So neglect and NIH scoring, 0 and 2 are fairly obvious. You know, no abnormality unless, like I mentioned, they've scored that 3 on item 1A. 2, patient can't recognize their own hand, or they're always looking right, never left, or left side of the room. 1 is the one that causes a lot of uncertainty in nurses, and per this lecture, they said if you're not sure, it's most likely a 1. Face, arm, leg, and testing is done, and they miss 1. You do visual fields, they miss, but next time they get it. Like I said, it's on a gradient. You will maybe have to assess this a couple times.
So I have to stop here. So do it once and document it as you see it.
Okay.
Your NIHSS stroke scale might change it, but don't give them multiple, tries, so to speak.
Okay.
Yeah. So you do it once, they get it, you score it. They don't get it, you score it. Either way, just score the way you see it. Don't goad them. Don't goad the patient to get it right. Don't give them an option. You do it the way you think should be done. You do it, they don't get it, you score it as it is.
I guess when I was saying to repeat it, maybe I misspoke, and I was just saying when you go back for another assessment, sorry, that's how I meant to say it, don't expect, or you might actually see something different because
Yeah.
it is on a gradient.
Sure.
So I spoke incorrectly. Motor weakness versus ataxia, and this is a big thing that I've seen on our floor, and I've talked to nurses since I've come back. A lot of us score people as ataxic when they're actually just weak. I've recently heard Dr. Doe tell somebody, that patient is not ataxic, they're actually just weak. So this requires judgment call and experience. I've heard this before, once you see an ataxic person, you know what you're looking for. So helping your fellow nurse out, if you have somebody and you know they're ataxic, especially with the newer nurses, grab them and say, come and take a look at this.
The point I'm trying to make that if you have ataxia, it's most clearly assessed in absence of weakness. If you don't have weakness, you can easily tell who has ataxia and who doesn't. If somebody has 3 out of 5 strength, let's say, they can barely hold it up and it's like drifting a little bit. Now you ask them to touch their nose. Right. They can barely get their arm to touch their nose, which is just not going to make sense because they're weak. So they can't hold their arm up. So it's drifting down as they're trying to reach their nose. So that's going to give an impression of ataxia. It's not ataxia, it's just they're weak.
And that's commonly what I think we as nurses do. And unfortunately, like posterior circulation strokes are often susceptible to a delay in diagnosis to the fact that this tool is flawed. So earlier in the beginning, some of you weren't here, we were talking about the NIH and how it's this communication tool between individuals. When we tell someone, this person's NIH score is a 2 versus a 20, we're talking about severity here. Now you bring up somebody being ataxic. There's only a score of 2. All 4 limbs could be affected. This is extremely disabling. This is going to change their plan of care, where they go afterwards once they leave the hospital. So this is kind of where the NIH can be unreliable. It also doesn't test for truncal or hemiataxia, which is extremely disabling. One thing to ask is, you ask a patient, do you find this disabling? A functional test is asking them to hold a pen. We'll go more into some other ways of testing motor function versus actual strength. I'm sorry, so when testing motor function items 5 through 8, this will give you visual insight, like Dr. Badruddin was just saying, as you could ask the patient too if they have a chronic condition. I had a gentleman one time and I noticed he winced when I was asking him to do the finger to nose. And he told me, I have chronic arthritis in my nose. But if it wasn't for that wince in his eye, his hand would move at one point, and it was actually just caused by the pain. Just a little education here, strokes affecting motor function, you're looking at your MCA, your ACA, PCA, subcortical. Basilar can result in either quadriplegia or tetraplegia.
What's the difference?
Between tetra and quadra,
Yeah,
2 and 4.
that would be hemiplegia or,
Or hemi.
yeah, so hemi would be one-sided, paraplegia would be lower half,
Mhm.
tetra and quadra are the same.
I wrote it down. So ataxia is just, the word means lack of order. So you're really looking for coordination. And this is a dysfunction of the brainstem. Unilateral sublesion is the other possibility. The difference between this and paresis is ataxia affects the coordination without affecting strength, whereas paresis is only strength. It has nothing to do with coordination. We know the finger to nose exam, we know the leg to shin. The leg to shin can be a little more difficult for people to do. A patient with a lesion in like the cerebral hemisphere will have an ipsilateral arm, will develop that intention tremor when nearing the target. And that's important too, because a lot of us do this, and we'll kind of go into some tips. We ask people to touch my finger, and we kind of only have them go out like this. They just wanted to show this real quick. It was interesting how their NIH was. They kind of put that in there. Ataxia is scored only out of proportion to weakness. But tips for scoring, eyes fully open. And maybe Dr. Badruddin can speak to this more, but they talked about fully extending those upper extremities, and that's kind of what I was saying. I see a lot of us do this, where people aren't fully extending, and they said it's when that elbow is about to fully extend, that's when that intention tremor kicks in.
So if you ever see me have them do a finger to nose, as their finger's coming closer to my finger, I'll move my finger back to kind of have them extend their elbow and reach out. That's when it becomes most apparent as they're reaching their target, then they'll just go like this. So, you know, if you're having it too close and they're going like this, there's not much distance here.
Mhm.
But as they're reaching it out, it will become more apparent. So that's why I will start out close by just so they get an idea of what they're supposed to do. But as they get once or twice, they get good at it, I start pulling my finger back to have them reach out more.
And again, tremor is not ataxia, so you know, you can look into their history or ask the patient if they're aware of their history, if they have something like essential tremors. If it is suspected, they suggested repeating the tests, upper and lower. If paralyzed, they're scored a 0. You only score what you see. Differentiating the two. It helps if you know where the stroke location is. Clues to know something else is going on if it's motor weakness. People saying, you know, I was really clumsy before I came in, or I was swaying a lot. Or we get the patient when we walk in the room and every single time they're leaning like this to the right side and we have to put them back. They've got that weakness on that side. Plus, when you do your motor strength, you can have them grasp your fingers, and if you notice it's equal on both sides, you know that they have strength in those hands. Call another RN in for input. Also, you know, again, score what you see. I wanted to bring up this implementation of a stroke nurse navigator. It's happening in a lot of stroke programs around the country, and it's just kind of interesting. We know that there's a lot of interdisciplinary teams that work with our patients. This includes, you know, from the acute phase to the post-acute phase. With a stroke nurse navigator, we're looking at somebody who works with these patients 90 days post-discharge. This hospital, particular one, ended up developing a pilot program for this new stroke care pathway, and the reason they incorporated the stroke nurse navigator was part of making them in the interdisciplinary team to improve not only the patient outcomes, but these quality metrics that they were keeping track of. And the metrics included the length of stay, the readmission rates, inpatient therapy days, 90-day total episode costs, patient demographics and clinical data they were collecting. Kind of a brief synopsis of like a nurse navigator's job description would be like personalizing education for that specific patient's stroke, doing like 2-day phone calls, reinforcing education, reviewing their medications with them post-discharge, ensuring that they actually follow up with the stroke neurologist afterwards, and actually seeing the patient in clinic and maybe kind of changing some stuff up with that personalized education based on risk factors that they assess.
So we do that actually, right? So Stephanie Banstra
Okay.
does that, and Sherry's on. So they do it as well. So we do all of those things actually.
Wonderful. Yeah, because in this study, it was like 1,400 patients. 48.3% of these patients were pre-care path. All causes of readmissions decreased like by 5%. Sorry. Inpatient therapy days increased 3.3 to 4.7
unit whenever it's
for
ready, but I told them the
hospitalization,
next
and
one,
total
like,
episode
the
costs
receiving unit, they were gonna have to
reduced
give
by
it.
about $1,000. I just want to bring up this
I
conference.
wouldn't even worry about it.
Dr.
Because we were
Badruddin
reviewing.
mentioned it. It's coming up
Okay.
later this year. For you people who weren't here in the beginning, I kind of said, you know, part of this, besides going to a conference and bringing back some material that is to help nurses do their jobs better, I wanted to empower nurses to start reaching out and asking, especially newer nurses like you, Chloe, to feel more comfortable asking about educational opportunities, or if you're unsure about something, because we want you guys to feel comfortable in your practice, and we want you to be doing your jobs correctly. So this will be going on, it's August 18th through the 20th. There's a link there that can be mailed out later. And the interesting thing about this is it's nursing focused. I'm not gonna read this all to you. You guys can go online and look at it. It's, you know, the AANN conference. But what's great about that, I mean, the AHA stroke conference was fantastic, but 90% of that was in that hyperacute phase, because that's where all your vendors are going to be. It's also a very serious part of the treatment. Something like this type of conference, as I read through it, it looks like they're also looking at more like IMCU level post-acute phases, also like rehab, and how do we get, you know, our readmission rates to lower. So it's something to look into, and if anybody's interested in it, I'll have more information about it. And that about covers it, so.
These are really fairly well-attended conferences. So I think you should all throw your hats in to go. I'm sure Jill will, I've just spoken to Jill, will pay for some nurses to go, but of course you can't pay for everybody to go. So there will be a set number of nurses. I don't know what that number is right now, but there'll be a few nurses that will pick. I'm not sure how Jill will pick, but it's up to her. But yes, I mean, do express your desire to go to this to your managers. You know, go to it. I want you to guys go to get out of this hospital and see how stroke is practiced elsewhere, so you can see what other ways of practicing strokes, you know, are, and you bring those lessons back home, so you can start improving this program. Thank you, Sam.
Thanks, everybody.
All right. The food's not gonna eat itself, so you guys eat food. And then we will talk about, and I guess we don't have a whole lot of time, so I can spare maybe 15-20 minutes, and we'll talk about a topic or two. Do you guys have anything in mind as to what you guys wanna ask, what you guys wanna talk about? Come on, man, that's the most disappointing thing. You gotta have questions. Questions, you know, patients you just saw recently, things that are not making sense to you, like why is this guy this way, why is Why did we do it this way with this person? Why did we give this medication? Or what is the cause of stroke? Or what is the exam finding? Whatever. Ask whatever you want. Katie, you want to ask me something?
I'm trying to think of something good here.
It doesn't have to be good.
Okay.
Simple. This has to be stupid.
Has to be
Don't
stupid. Well, I
don't
can't
go
say.
for a Mach 3 fighter jet. Go for a Cessna.
Okay. So I guess just, because I've seen with the visual field testing, I've seen the numbers done and the moving the hand. Do you have a preference when you assess?
I don't have a preference.
No?
I-
Both appropriate and equally tough?
Yeah, so I think it's, in terms of, I've now, after saying that, I don't have a preference. It's easier if you do finger movement for the patient, because they're not focused on counting fingers. Otherwise, they become obsessed with counting fingers, and they're not, playing along with you. What you're not really testing is their visual acuity, whether they can count fingers or not. You're trying to check their visual field. Visual field is different than visual acuity.
So if you're wiggling your fingers, are you saying, okay, tell me when you see my hand moving, or just, do you see my hand moving?
Do you see my hand?
Okay, because then they could just say yes too, even if they don't.
Yeah, but then you say, okay, so you start out and say, is my hand moving?
Uh-huh.
Start moving,
Okay.
right?
And then,
And then say, how about now? It is, how about now?
okay.
So you have to trick them a
Yeah,
bit
okay.
to figure out whether they're truly seeing it or not.
Very good.
All right. So what else do you want to know?
Well,
We
you know
can
what?
we can go over an exam
I have
briefly.
Kayana. She's
Yeah.
kind of an interesting case because she's
Yeah,
young.
she's very young. Yeah.
I don't know if, I was told she's got that occluded left internal carotid artery.
It's not occluded, but it's very severely narrow.
Does she have to go to Chicago for that?
Yeah, she's gonna have. She's gonna have to go to UIC for that.
Okay.
Because what she needs is maybe an ECIC bypass or EDAS, duroangiosis. So, what in particular? I mean, it's a complex case. We can start talking about it, but what in particular do you have? I'm gonna ask about it.
So that's the cause of her stroke, obviously, then.
That's definitely the cause of stroke. What worries me is nobody has really looked into it so far.
That's what I was wondering. I didn't know
Until
that, or if
she-
she had a clotting disorder. I didn't know.
Until she comes to our doorsteps.
Right.
And then, so I don't, because she seems like she has had multiple strokes in the past, and she had been seen by some place around here. I don't know where she was seen.
Okay.
And nobody caught on to the fact that she has severe stenosis.
Right.
And do something about it. So now she comes in with a new stroke, and the more we wait, the more the ship's gonna sail.
I know.
And it's gonna be too late for us to do anything. So, yeah, it's very unfortunate. That gentleman had a thalamic hemorrhage. He's aphasic, he's completely bleeding on the right side. So,
The person.
yeah, so it depends on the stroke, where the stroke is, To some extent, you are correct that, they can maybe be able to talk and this and the other. Because it is very difficult to have a large enough hemorrhagic stroke, a hemorrhagic cortical stroke, that, gives them deficit but doesn't kill them, if that makes sense to you. For example, let's say, in order to make somebody aphasic and hemiplegic, you need to knock out this part of the brain, the left part of the brain, okay? You block off a blood vessel with a clot, this part of the brain becomes ischemic, and they are no longer able to talk and or move their right side. But it is ischemic, right? Meaning that their blood is not flowing, so the brain tissue is dead. Now imagine a similar stroke happening due to hemorrhage in this large of part of the brain. Imagine this large of a hemorrhage. That is large enough to kill them. So we do see these patients, but they're usually dead by then. You see my point? So it's not that they don't get it. Yes, they get it. But if you had a hemorrhagic stroke as large as a ischemic stroke, you'd be dead by then. So we see some of these things with smaller hemorrhagic strokes, and we see it all the time. We have a gentleman downstairs in the ICU who has significant weakness on the right side. He can't move his right side at all. He had a thalamic hemorrhage, can't move his right side at all. In February or March, we had like 3 patients back to back, all thalamic hemorrhages, all extending into the corticospinal tracts, hemiplegic completely. Could not move their right side at all, or left side, whatever. You get the point. So no, it's not entirely true that you don't. You do get patient with severe deficits. Thing about hemorrhagic, and I'll just add one more thing here. Thing about hemorrhagic strokes is that the initial consequences are worse in a hemorrhagic stroke than they are with a ischemic stroke. Because the blood is a space occupying lesion, right, and causes increased ICP, expansion of hemorrhage and things like that. So if you survive the initial hemorrhage, the outcome is a little bit better in hemorrhagic outcome, because what happens when it bleeds, the blood dissects the tissue and pushes the tissue apart. So if these are the fibers running in the brain, there's bleeding in there, and the blood will just separate out the fibers. It's not entirely destroying it. I mean, there's some destruction going on, but it's not entirely destroying it. So when the blood resorbs back into the body in 6 to 8 weeks, the fibers come back together, and the healing is much better. When there's a ischemic stroke, the whole thing just dies. It gets killed off. So now that there's no coming back from that. So a hemorrhagic stroke, people will have better outcome if it doesn't kill them. The ischemic stroke, it is more likely not to kill them, but the outcome is not so great either, if that makes sense. Yeah? Anything else? You want to, troubleshoot his question about exam? He had brought up so many exam questions. How to examine people, blah, 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 blah. Neglect, visual fields, cranial nerves. You're not asking me any of those questions.
Do you feel like sometimes if you get a patient like who's globally aphasic, you see people assessing them as unaccessible as far as like their visual quadrants go? Or altered mental status?
Yeah, because I think they might just assume.
Because they can't follow
Right.
directions.
Mm-hmm.
And again, Dr. Badruddin, I don't know if this...
So there is a way to do that, exactly. It's not entirely true that you shouldn't.
No, I was going to say I had an idea. I
Yeah.
didn't know. Just because if you initially raise your hand to do confrontation, they might look up there. If you raise your hand like this and then come in and do confrontation in those areas, if that is kind of considered a legitimate
It
way.
is definitely legitimate. So if you look at the initial NIHSS stroke scale training videos, that's exactly what they do.
Okay.
Right? Even if the patient's eyes are not open, the examiner will open the eyes with his or her hand and then do the confrontational testing to see if they blink or not. That's exactly what you're supposed to do.
Mhm.
Alright. One thing when you were talking about, I was thinking, the NIHSS stroke scale, the reason nurses don't keep up their skills, I mean, it's not a huge issue on our floor because you guys do it all the time. But on the other floors, they don't do it as often. So, one point you had brought up in your presentation, if you're certified for an NIHSS stroke scale, are you good? The question is absolutely not. Whether you're certified or not doesn't mean anything, right? Because you take that online course to get the NIHSS stroke certification. You have this rote memorization for that half hour. You're concentrating on how to get this right. You get it right, and the 31st minute you've forgotten it all. Unless you keep doing it, you don't become good at it, right? So you have to become really good at it, doing it all the time and doing it properly, all right? So if you really want to see it how it's done well, run to the stroke alert with the ICU nurses. They do a good job of it, right? It's not because they're smarter than you. It's not because they have more training than you. It's just they do it so often, right? They do it so often, so they just get better at it because they're just continuing to do it, right? So you guys should continue to do it. I guess with the new model, you're not going to be doing it as often. So I'm afraid that your skills will become a little rusty. The new model, you're doing it only 3 times for every patient per admission. On the day of admission, 24 hours after, and on the day of discharge. That's about it. So you have to, become good at it and revisiting the video, right? Repetition helps. I don't know how many times I repeat myself with everybody, going with the same talk over and over and over again. It helps, because it makes those stronger connections in the brain when you hear the same thing over and over and over again. Okay. What else? I think we'll call it done in a minute, but what else you guys want to talk about?
Is there any rhyme or reason behind repeat imaging if there's no change in status, like as far as the timing of it in comparison to their NIH scale or their condition, or like a guideline that you follow?
There
Always
is
with-
no guideline for repeat imaging. So why do we repeat imaging? There are a few reasons to repeat imaging. One, the patient cannot get an MRI because they have a pacemaker, they have bullet in their neck or whatever. Right? So they can't get an MRI. And initial CT was negative. Yet they're sitting in front of you, hemiparetic, NIHSS stroke scale of 6. There's no change, but they're still weak, right? They came in hemiparetic, they're still hemiparetic. So if you can't get an MRI, your initial CT was negative. Why was your initial CT negative?
Have it not completed, the stroke been complete, or?
Yeah, the tissue is not boggy enough to show up on the CT, not just yet, right? It takes 4 to 6 hours for the acute stroke to show up on CT scan. We did an initial CT scan in the ER. It was negative, but it doesn't mean anything, right? So you will repeat a CT scan 24 hours later, 36 hours, whatever, to figure out, did they have this person have a stroke or not? Because now you're able to identify a stroke on the CT scan, because you can't get an MRI, so you're getting another CT scan to figure out that they had a new stroke or not. So that's number one reason why you might repeat imaging. What is the second reason? Second reason is that if they had a large stroke to begin with, right? Now you're looking at swelling. Right? Did they swell more? Did they swell more to be accounting for change in examination? Or even if they didn't have a change in examination, is this somebody that we need to be super vigilant about? Are they swelling more and more and more, and are they at the cusp of herniation? Do we need to intervene? Do we need to send them to ICU? Do we need to give them a hypertonic saline? Do we need to operate on them? Whatever it is, right? So that's the second reason why you might repeat imaging. Third reason you might repeat imaging is that they have a material clinical change, right? They came in with, exam X, now they're exam X plus 2. That's a significant change. Okay, you have to repeat the CT scan. What else was going? Did they have a new stroke? Did their stroke expand? Right, they came in with dime-sized stroke, now it's a quarter-sized stroke or larger than that. Do they have another stroke in a different territory? Right, so you might have a repeat imaging because of that. Sometimes we have patients who have an MRI. An MRI is negative, right? Somebody comes in with clumsy hand, they can't button their shirt or zip up their jackets or whatever, and they're dysarthric. I'm just using this because there's a syndrome called the clumsy hand dysarthria syndrome. So they come in with this kind of phenomena. There's a stroke. It has to be a stroke, right? You do an initial MRI and it's negative. You don't see anything. But that doesn't mean they don't have a stroke, right? So you repeat an MRI 1 or 2 days later, because just like the CT can be negative initially for acute stroke, an MRI can be negative initially for an acute stroke as well, especially if it's a tiny stroke. Very, very tiny stroke may be negative, or sometimes the stroke is very small and the MRI cuts miss it. So there is not enough resolution of the MRI to detect a stroke. So the MRI cuts would miss it. So you repeat it next time in the hope that it will catch it. Sometimes I would even request a 3 Tesla MRI to be done instead of a 1.5 Tesla. So Tesla refers to the strength of the magnet of the MRI. The stronger the magnet, the higher the resolution of the brain or any organ that you're imaging. So then I would request a 3 Tesla MRI to make sure that we have high enough resolution to catch that stroke. Okay. Why do we emphasize on imaging so much? It's not because we don't know how to diagnose a stroke without imaging. I used to be a neurologist. I know how to diagnose a stroke by going over examination patterns and where the lesion is and blah, 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 blah. But because we want to know what the stroke pattern is and where exactly the stroke is, because it has a huge implication on etiology, why somebody had a stroke. And you need to know why somebody had a stroke, because if you're going to prevent another stroke from happening, you need to know why, right? Let's say, and we were having this discussion earlier, I think, that I was having a discussion with a medical student, I think. Somebody has a carotid artery stenosis. And the stenosis is 60%. Okay. So actually I had this patient in my clinic. A lady came in who had a stroke, had about 60% stenosis of the carotid. I did not stent her. And the medical student asked me, well, why didn't you stent it? It's 60% stenosed. Had the patient had the stroke in the same territory. It was a right ICA stenosis, right ICA embolic pattern stroke. This only could have been the cause. I said, I can. It's not a big deal to stent this. But what if she has a cardioembolic phenomenon? Then what I have done, I have wrongly blamed the carotid and ignored the heart. And so I fixed the carotid, and a year or 2 years later, she has another stroke. Why? Because I treated the wrong thing. Treated the wrong thing. So it is very important for you to know the stroke pattern, to know the stroke etiology, so you can fix the right problem and don't fix the wrong problem. Make sense? So that's why we do imaging, get a CTA. Today, we had the patient that we are seeing here on the floor right now. Had a hip surgery for a broken hip, comes in, ACA territory stroke. Everybody's calling it an embolic stroke. Yeah, it is an embolic stroke. I guess I could give you that. All right? And we were consulted for a PCA territory stenosis, PCA stenosis. The stroke is in the ACA territory, okay? And we were consulted for the PCA. I look at it and I said, it doesn't make any sense. There's MRA done, but MRA is usually poor quality. So we get a CTA on her. CTA. ACA is occluded here. Not picked up on MRA. We know what the problem is. It's an embolic stroke, but it didn't come from the heart. Intracranial atheroid. It's an intracranial atheroid. So this lady doesn't need a loop recorder and all that sort of stuff. She needs aggressive risk management for intracranial atheroid, because that's where her stroke is coming from. So it's very, very important for you to know the etiology of what causes stroke and treat the right cause of the stroke. Because otherwise, I don't like to play fast and loose with my diagnosis. There are some people who would just say, oh yeah, you had a seizure. Oh yeah, it was a mini stroke. Oh yeah, you had a stroke. MRI, negative. CT, negative. Imaging, negative. Oh, why are you calling it a stroke? There's nothing to prove that it had a stroke. I had a perioral numbness. Oh yeah, I had a mini stroke. Show me a mini stroke that does cause perioral numbness. None. Zero. Zilch. Zippo. Why are you calling it a TIA? It's not a TIA. Right? So if you're going to give a diagnosis, you better have a good reason for it. Prove it to me. Prove it that this can be the cause. This it's a plausible explanation for it. Not possible. Plausible explanation for it. Then maybe I'll buy it. Otherwise you are just giving me nonsense. So that's why we emphasize on imaging, because we're trying to be mindful of what disease diagnosis we give to our patients. It's very important to give them the right. And if you don't know it, be honest with them and say you don't know it. Oh, I don't know what it is. And Katie just has been working with me for 2 weeks. She's already know many a times I go in the room and said, I don't know what it is. I'll tell them, especially these patients come in with vague symptoms, I was dizzy or I was whatever, right? And we do an MRI and these patients are expecting an answer. And I tell them, I would say, look, I know what it is not. It is not a stroke, but I can't tell you what it is. I can only tell you what it is not, and it's not a stroke. Right? So it's just as important to give a diagnosis of what it is not as it is to give the diagnosis of what it is. And if you don't know it, you don't know it. Say, look, I don't know it. Just be honest with them, I don't know it. It takes a lot of courage to say that. I don't know it. That's fine. Okay. Any questions? All right, guys. I think we'll wrap it here. We'll do it again next month.